Welcome to Pediatric Podcast for PedsCases.com.
Hello, my name is Larissa Shopka, and I'm a pediatric resident at the University of Toronto.
Hi, I'm Dr. Chris Novak. I'm a hospital pediatrician at Alberta Children's Hospital. And after years of working together on Peds cases, this is my first time recording with Larissa. So nice to see you.
Good to see you too, Chris. This podcast was produced by Peds Cases and the Canadian Pediatric Society, CPS. The goal of this podcast is to summarize the 2021 CPS practice point titled Emergency Management of the Pediatric Patient with Convulsive Status Epilepticus. The podcast was developed with Dr. Kyle McKenzie, a pediatrician in Red Deer, Alberta, and one of the authors of the practice point. To view the complete practice point, please visit www.cps.ca. The script for this podcast can be accessed at www.pedscases.com. Prolonged seizures are a presentation that many healthcare providers will encounter, whether in the emergency department or inpatient setting. Pediatric status epilepticus is also a frequent indication for ICU admission. Status epilepticus is a neurological emergency, so it's important to have a practical and timely approach to it. The current CPS position statement replaces a previous version from 2011 with an updated treatment algorithm and new medication recommendations. We will cover all of this in detail later on in the podcast. It is important to remember that CPS guidelines apply to children and infants older than 1 month of age. Please refer to neonatal-specific resources for any patients under 28 days of age.
All right, so let's start with some objectives. After listening to this podcast, the learner should be able to, number 1, define convulsive status epilepticus. Number 2, list common etiologies of convulsive status epilepticus in children. And number 3, initiate basic management of pediatric CSE, or convulsive status epilepticus, as per the CPS algorithm. This will include maintaining adequate airway, breathing, and circulation, ordering appropriate medications to terminate the seizure, and finally, diagnosing life-threatening causes of convulsive status epilepticus. For a further review of seizure classification, epilepsy syndromes, and long-term epilepsy management, please listen to other podcasts and notes from Peds Cases. Okay, so we'll begin with a clinical case to provide some context, and we'll return through it throughout the podcast to apply what we've learned. So let's get started. You're working in the emergency department when Liam, a 3-year-old male, is brought in by EMS with concern for a prolonged seizure. His parents called 911 after finding him unresponsive with jerking movements of all 4 limbs. He was given 1 dose of intranasal midazolam by EMS en route. The movements have persisted and it's now been 15 minutes. How do you manage the situation?
To start, let's talk about what status epilepticus is and why it matters. When we say status epilepticus, what do we even mean, Chris?
The International League Against Epilepsy defines status epilepticus as a single epileptic seizure lasting more than 30 minutes, or a series of seizures where function is not regained within the 30-minute period. However, the definition of status epilepticus and what we use in practice often differ, since we want to stop seizures early to prevent brain injury. Research has shown that early treatment is more effective and that delays can cause increased morbidity and mortality. You may hear the terms early or impending status epilepticus, which refers to continuous or intermittent seizures lasting longer than 5 minutes without full recovery of consciousness in between. The CPS and most people in practice would recommend treating within about 5 to 10 minutes. So throughout the rest of the podcast, there's a couple different terms that could be used to describe this. So the position statement uses the term convulsive status epilepticus, or CSE, frequently. However, for most of the podcast, we'll probably use the term status or status epilepticus, recognizing that there is non-convulsive status epilepticus in other forms, but for sake of ease, we'll just use those terms. Okay, so the annual incidence of pediatric status is about 10 to 73 episodes per 100,000 children per year. Status is associated with significant morbidity and mortality. The risk of mortality in status epilepticus is between 2.7 and 8%. And for morbidity, the risk is 10 to 20%. These morbidities can include hemodynamic instability, neurologic conditions, long-term neurologic deficits, cognitive impairment, and long-term behavioral concerns. In general, these outcomes are determined by the underlying cause, but the length of the seizure can also play a role.
Now that we know what status epilepticus is, let's talk about some of the common causes.
So one way to categorize etiology is by time frame, i.e. acute versus remote. The most common cause of status in children is a prolonged febrile seizure. However, other acute causes include CNS infections like meningitis or encephalitis, trauma, metabolic and electrolyte derangements like hypoglycemia, hyperglycemia, hyponatremia, and hypocalcemia, toxin or medication ingestions, and also in children with epilepsy, subtherapeutic levels of antiepileptic medications. Patients can also have remote pathology that lower their seizure thresholds. This can include perinatal HIE or hypoxic ischemic encephalopathy, cerebral dysgenesis or other congenital brain anomalies, previous brain injury, such as from stroke, trauma, or meningitis, along with other progressive neurodegenerative disorders. Sometimes convulsive status epilepticus can just be idiopathic as well.
What should be going through your mind when you're called to the bedside of a patient who is seizing?
So you can break down the acute management of status into 4 main parts. Number 1, maintaining ABCs, airway, breathing, and circulation. Number 2, stopping the seizure and preventing recurrence. Number 3, managing any refractory convulsive status epilepticus. And number 4, diagnosing life-threatening causes of status epilepticus. Let's go through it one by one. While it can be easy to focus on trying to stop the seizure, your first and most important priority is to maintain the airway. It's all about ABCs, and the airway comes first for a reason. Inadequate airway maintenance is the most critical immediate risk to patients with convulsive status. They can experience upper airway obstruction related to decreased tone and may require help with ventilation. Hypoxia is also common. Maneuvers to help manage the airway include positioning. You can do a chin lift or jaw thrust, and this can open the upper airway to relieve obstruction. You can also place a child on their side and suction any easily accessible secretions before repositioning the patient on their back. Patients should be kept in a safe position for the duration of the seizure, but not restrained. The patient with a prolonged seizure should be placed on cardiorespiratory monitors with oxygen saturation monitors and receive 100% O2 by face mask. Watch very closely for airway compromise, respiratory failure, hypotension, or cardiac arrhythmias. Vital signs that commonly accompany seizures include tachycardia and hypertension, but these should resolve once the seizure stops. If your patient is showing signs of respiratory depression or hypoxia, despite receiving 100% oxygen via mask, you should be thinking about assisted ventilation. Red flag signs for severe hypoxia include bradycardia, hypotension, and poor perfusion. These should cue you to immediately secure the airway, either by bag valve mask ventilation or intubation or an alternative airway. As with any emergency situation, make sure you're calling for help and mobilizing the appropriate resources for your situation. ICU should be consulted when there is respiratory and hemodynamic compromise associated with seizures, as well as in cases of refractory status epilepticus. Remember, the priority is ABCs. So for the next part, Larissa, do you want to talk about some key principles to keep in mind when managing status?
For sure, Chris. As with other acute presentations, you should take a focused history and physical exam. This will help you identify possible life-threatening causes of status epilepticus and may also yield information that could influence which medications you use to try to stop the seizure. Make sure you are asking about any associated symptoms, history of seizure disorder, medications, and drug allergies. Don't forget to ask for stat glucose. Point-of-care glucose testing is quick, easy, and can significantly change your management of status epilepticus. You don't want to miss hypoglycemia. It's potentially life-threatening, but reversible. A common mnemonic for emergencies in pediatrics is ABCDEFG, airway, breathing, circulation, and don't ever forget glucose. You'll also want to establish IV access as soon as possible for medication administration. As with any emergency situation, 2 large bore IVs are ideal. If you have difficulties with gaining access, you do have options for other routes of initial medication administration. However, you should think about escalating to placing an intraosseous line if you can't get IV access and the patient is decompensating, or if you get to the point where the seizure requires treatment with second-line medications. You can consider sending off some blood work with this to investigate other potentially reversible causes of status epilepticus. More on this to come. But obtaining these tests should not delay medication administration. Continuous cardiorespiratory monitoring is also important if you end up giving any antiepileptic medications. Antiepileptic medications can lead to loss of airway reflexes, respiratory depression, hypotension, and cardiac arrhythmias. So it's important to monitor for these complications and to be prepared to deal with them. I know it sounds like a lot, but in real time, often many things can happen at once. For example, someone can check a point of care glucose while you take your focused history, while another team member draws up first-line medications to have on hand. Coordinating the medical team is key. Let's move on to discussing how to stop the seizure. As mentioned earlier, you should think about giving antiepileptic medication if the seizure is prolonged more than 5 minutes, or if your patient experiences recurrent seizures in a short period of time.
Yeah, that's correct. Realistically, you should start thinking about this even before the 5-minute mark. It takes time to draw up medications and to get vascular access. If you suspect you could be moving towards status epilepticus, it is very reasonable to ask a team member to start getting IV access and drawing up medications.
So which medication do you choose for first-line treatment?
In general, there is very limited evidence for a gold standard protocol for pediatric status, and different guidelines have minor variations. Intervening quickly may be more important than specific medication selection. Remember, this is a medical emergency. The CPS statement has a very helpful figure outlining their treatment algorithm and a great table comparing different antiepileptic drugs. We highly suggest saving it on your phone for quick access on the go. So let's delve into these recommendations. The first-line medications for treatment of status is benzodiazepines. For pre-hospital management, midazolam is preferred because it can be given in a variety of routes: intranasal, intramuscular, as well as buccal. Please refer to the CPS statement for full details of dosing. Alternatives to midazolam include buccal lorazepam. Once you're in hospital, the preferred route of benzo administration is IV. However, medication administration should not be delayed while vascular access is being secured, and other routes such as IM, intranasal, and buccal can also be used in the interim. In terms of options for IV benzodiazepines, you can use midazolam, lorazepam, and diazepam. Lorazepam IV or midazolam IV or IM all have similar efficacy and are the recommended first-line agents for treatment. These have been shown to be more effective than diazepam or phenytoin. We suggest you pick one benzo and memorize the dosing as your go-to. For example, lorazepam is 0.1 milligram per kilogram to a maximum of 4 milligrams IV. Side effects of benzodiazepines include hypotension, respiratory depression, and sedation. Typically, these are seen after more than 2 doses, but it's important to be aware and prepared to manage them.
Okay, so you've given a benzodiazepine as your first-line medication for status epilepticus. You reassess your patient after, and they are still seizing. Chris, what do you do next?
Okay, if your patient is still having a seizure 5 minutes after the first dose of benzodiazepine, then you can give a second. If you didn't give the first dose via IV, preferable to switch to an IV route for the second dose if possible. After more than 2 doses of benzodiazepines have been given, including ones given pre-hospital, and the seizure is still ongoing, it's time to move on to second-line medications. As a general rule, if you're moving on to a second-line antiepileptic medication and you don't have IV access yet, now is a good time to think about an IO or intraosseous for medication administration.
Second-line treatment consists of loading doses of antiepileptic drugs, such as fosphenytoin or phenytoin, phenobarbital, levetiracetam, or valproate. How do you choose between these options?
Overall, efficacy, availability, side effects, and the individual clinical scenario all play into your decision-making. Current evidence suggests that for benzodiazepine refractory seizures, fosphenytoin, levetiracetam, and valproate are all equally effective. Fosphenytoin/phenytoin and phenobarbital have been the most commonly used second-line agents in Canada because of familiarity and availability. However, IV levetiracetam came to the Canadian market in 2019 and is really changing things. It's a nice option in patients where you're worried about respiratory and hemodynamic stability. A second new option is IV valproate. It's currently in short supply, and as of July 2020, it's only available through Health Canada's Special Access Program. One other consideration is route of administration. All of these second-line medications require vascular access except for fosphenytoin, which can be given intramuscularly. So now let's review each of these medications in detail.
So phenytoin and phosphonatoin are sodium channel blockers, with phosphonatoin being the water-soluble prodrug of phenytoin. Phenytoin has a high pH, so it can cause severe subcutaneous extravasation injuries. This risk doesn't exist with phosphonatoin, and phosphonatoin also has the flexibility of being administered intramuscularly. But phosphonatoin is more expensive and not as widely available as phenytoin. Evidence suggests that phenytoin stops about 50 to 80% of prolonged seizures. In addition to broad availability, it also has less respiratory effects than phenobarbital. Potential side effects of phenytoin and phosphonatoin include bradycardia, arrhythmias, and hypotension. You should also avoid phenytoin and phosphonatoin if you suspect the seizure is caused by toxin ingestion or drug withdrawal, as it could be harmful in theophylline or tricyclic antidepressant ingestions. The dosing of phosphonatoin is 20 milligrams per kilogram to a maximum of 1,000 milligrams. Of note, phosphonatoin should always be ordered as milligrams of phenytoin equivalents. This should be common practice in hospital pharmacies, but essentially the dosing of phenytoin and phosphonatoin is a 1-to-1 equivalent ratio. An additional 5 milligrams per kilogram of phosphonatoin or phenytoin can be given if the initial dose is ineffective. But if a patient is already on phenytoin for maintenance antiepileptic therapy, this initial dose should be lower, 5 milligrams per kilogram only, with further dosing guided by drug levels. Always remember that phenytoin and phosphonatoin should not be used in combination with each other. They are considered equivalent, so if one has already been given, do not give the other. Practically speaking, it's also helpful to know that it takes about 5 to 10 minutes to infuse this medication. Now let's move on to talking about phenobarbital.
The efficacy of phenobarbital is similar to phenytoin, but phenobarbital does have a higher risk of respiratory depression, especially in patients where benzodiazepines have already been given. Phenobarbital has a similar mechanism to benzodiazepines, so it actually might be less effective in treating seizures that fail to respond to first-line treatment. Potential side effects of phenobarbital include hypotension and sedation. Given all these considerations, you should be cautious about using it in patients with respiratory depression, hemodynamic instability, and probably should pick a different medication. That being said, there are instances where phenobarbital may be a good choice. Phenobarb may be the best second-line option for infants less than 6 months, for febrile status epilepticus, seizures caused by toxin ingestion or drug withdrawal, or in cases when your patient is already on phenytoin maintenance. Another benefit of phenobarbital is that it tends to be very easily accessible and is available in most hospital pharmacies. If you're giving phenobarbital, the dose is 20 milligrams per kilogram to a maximum of 1,000 milligrams. However, this infusion must be run over 20 minutes. Now, let's talk about the new additions to the CPS treatment algorithm.
First up is levetiracetam, more commonly known by its trade name of Keppra. IV levetiracetam has been available in Canada for the past couple of years. Data suggests it has similar efficacy to other antiepileptics, such as phenytoin, phenobarbital, and valproate. And overall, it also seems to be better tolerated, with fewer respiratory and cardiac side effects. It's a really good choice in children who are unstable. Another benefit is that it has relatively fewer medication interactions than some of the other antiepileptic medications. In terms of side effects of levetiracetam to be aware of, post-ictal psychosis has been reported, but the overall risk of this is low. The dosing for levetiracetam recommended by the Canadian Pediatric Society is 60 milligrams per kilogram to a max of 3,000 milligrams.
Okay, the last new addition is IV valproate. IV valproic acid, or valproate, has similar efficacy to phenytoin, phenobarbital, and levetiracetam, with potentially less respiratory and cardiovascular side effects. It is also a useful second-line agent for children with epilepsy who are already on valproate but have had poor adherence to this medication. Dosing is 30 milligrams per kilogram to a maximum of 3,000 milligrams, with an additional 10 milligram per kilogram top-up that can be given if it's initially ineffective. However, the biggest problem with valproic acid is availability. Right now in Canada, IV valproic acid is only available through Health Canada's Special Access Program. It's also important to know that valproic acid is strictly contraindicated in children with mitochondrial disease that's either suspected or confirmed. This can include children under 2 years of age with unexplained developmental delays. You should also be cautious in patients with pre-existing liver disease.
So what happens if you give one of these second-line agents and it doesn't stop the seizure? Are there any recommendations for what to pick next?
If the patient has received one second-line medication and the seizure is still ongoing 5 minutes after their first medication has been delivered, then you can give a different second-line medication. If the patient is less than 18 months of age, another consideration is pyridoxine or vitamin B6. This can be very useful in the case that seizures are caused by an undiagnosed metabolic disorder related to B6.
What happens if you're in a situation where you've given 2 doses of your first-line antiepileptic medications, your benzodiazepines, and then 2 doses of your second-line drugs, and still the seizure has not stopped?
Yeah, if your patient is still seizing after 2 second-line antiepileptic medications, this would generally be considered refractory status epilepticus. However, some definitions do require a duration of 1 hour to call it refractory. For any case of refractory status, you should be consulting specialty services, including intensive care and neurology. Second-line medications for status are less likely to be effective after the first hour of seizure activity, and other treatments may be required. This can include continuous midazolam infusions, propofol, high-dose phenobarbital, or pentobarbital. These all have significant respiratory and hemodynamic effects and require escalation of care to the ICU setting.
That was a lot of information. To recap, the CPS algorithm advises that convulsive seizures lasting longer than 5 minutes be treated with antiepileptic medications. Benzodiazepines are the first-line medication for status epilepticus. You would give a dose of benzodiazepine, then repeat again 5 minutes later if ineffective. Once 2 doses of benzodiazepines have been given, it's time to escalate to second-line antiepileptic drugs if the seizure still persists for more than 5 minutes after. Your second-line medication choices are fosphenytoin or phenytoin, phenobarbital, levetiracetam, and valproate. Availability, efficacy, and side effect profile will help you tailor your selection. If one second-line medication is ineffective, try a different one. However, if the seizure continues after this, the patient is in refractory status epilepticus, and it's time to consult ICU to discuss escalation of care. The whole time you're managing a patient with status epilepticus, you should be providing supportive care and monitoring for respiratory depression, hypotension, and arrhythmias, which would necessitate earlier consultation with intensive care.
That sums it up. Perfect. It's important to remember these are just guidelines. Patients with complex epilepsy histories may have individualized seizure plans, but the same general principles apply.
We spent a lot of time talking about management and medication algorithm for status epilepticus. What about investigating for potential causes of it? What tests should be considered?
Yeah, this will vary depending on your patient's individual clinical scenario. All patients should have a history and physical to assess for precipitating causes with special attempts to identify signs of infection, intoxication or ingestions, trauma, and focal neurologic deficits. Investigations are really going to be tailored to the patient's clinical scenario. Remember, the most common cause of status is a prolonged febrile seizure, in which case an extensive workup is usually not required. Similarly, if children have known epilepsy, then an extensive workup may not be indicated. Lab tests should be considered when the etiology of status is unclear. In addition to the glucose that we already discussed, labs can include a CBC, electrolytes, blood gas, blood cultures, and antiepileptic drug levels if the patient is already on maintenance therapy. Extended electrolytes, including calcium, magnesium, liver enzymes, lactate, and ammonia, can also be included depending on your clinical suspicion for metabolic derangements. If you suspect meningitis or encephalitis, IV antibiotics and antivirals should be urgently administered. Do not delay treatment to draw cultures. The LP can be deferred until after the patient has stable vitals and has stopped seizing, and there's no concern for increased ICP. A CT head should be performed if there's a history of trauma, signs of raised ICP or cerebral herniation, focal neurologic deficits, or an unexplained loss of consciousness. MRI may be helpful for more detailed assessment, but it's not always readily available. It is key to remember that if there are signs of increased ICP or herniation, this is your first priority. Elevated ICP must be treated immediately before any further investigations or imaging. Also, keep in mind a normal CT head does not exclude increased ICP, and that an LP is contraindicated for any patients with raised intracranial pressure. Always have intoxication on your differential. When there's strong suspicion for intoxication, consider using activated charcoal once the seizure has been stopped and the airway is protected.
We've spent the podcast discussing convulsive status epilepticus. Now for a quick word on non-convulsive status epilepticus. Non-convulsive status epilepticus refers to persistent change in a patient's baseline level of consciousness and accompanying continuous epileptiform changes on EEG with no clinical motor manifestations. You would want to get an EEG to rule out non-convulsive status epilepticus if your patient does not recover level of consciousness as expected once a convulsive seizure has stopped, or when neuromuscular paralytic agents have been given. If EEG is not available, you should discuss with neurology and consider starting empiric treatment for non-convulsive status epilepticus. Now let's return to our case to apply what we've learned before we wrap up the podcast. You begin your assessment of Liam as your team attaches a heart rate and oxygen saturation monitors. His airway appears patent. He is breathing spontaneously and receiving oxygen via face mask, as started by EMS. He is tachycardic and mildly hypertensive, but peripheral perfusion is maintained. Liam is unresponsive on exam, with tonic-clonic movements of his extremities. His mother tells you that while he had a fever and cold the past couple of days, she didn't think it was anything serious. She was shocked and scared when he started to seize today. He is normally healthy and has no regular medications or allergies. There is no history of trauma or known substance ingestion. You ask for a point of care blood glucose, which is normal, IV insert, and order a dose of IV lorazepam, 0.1 milligrams per kilogram. Unfortunately, despite this, the seizure continues. Given that Liam has already received a total of 2 doses of benzodiazepines, including the dose of midazolam with EMS, you escalate to second-line agents. You choose phenobarbital given that he has febrile status epilepticus. You readily have it on hand, and because he is currently stable from a hemodynamic and respiratory perspective. Liam's seizure continues, and 5 minutes later, you give a dose of IV levetiracetam, which quickly stops the seizure with no significant cardiorespiratory compromise. You suspect that the etiology of Liam's status epilepticus was prolonged febrile seizure, and you continue on with your assessment.
We've made it to the end of the podcast, so let's end by reviewing a few key take-home points. Number 1, status epilepticus is a neurologic emergency. Your top priority is maintaining respiratory and hemodynamic stability. Number 2, anti-epileptic medications should be given promptly for prolonged seizures greater than 5 minutes, or recurrent seizures within a short period of time. Number 3, first-line medications to terminate status epilepticus are benzodiazepines. If your first dose doesn't work, try one more. Then move on to second-line medications. Second-line medications include fosphenytoin, phenytoin, phenobarbital, levetiracetam, or valproate. Your choice will depend on availability, side effect profile, and efficacy. If you tried one of these medications and it's ineffective, try a different one. Also, consider giving pyridoxine in children less than 18 months of age. Number 4, if you've given 2 second-line medications with no response, this is considered refractory status epilepticus. In this situation, you should be consulting ICU for consideration of transfer of care, as well as neurology. Finally, number 5, keep in mind potentially life-threatening causes of status epilepticus. Investigation should be guided by clinical suspicion, but remember, your first priority is stabilizing the patient. This concludes our podcast reviewing the CPS practice point on emergency management of pediatric patient with convulsive status epilepticus. We hope you found it helpful, and thank you for listening.
Check out www.pedscases.com for more great podcasts, videos, interactive cases, questions, and more. Press subscribe on iTunes to get access to all of our podcasts. If you like what we do, please leave a review on the iTunes store, share with your friends and colleagues, or think about getting involved.